Okay.
Okay, let's start.
All right. So, welcome everyone to this webinar on, as you can see on the title slide, on healthcare ecosystems, the regulatory systems, and access pathways. My name is Tamás Beretsky, and I'm a patient advocate myself. I've been working in the HIV, viral hepatitis, and mental health fields for about 17 years now as a patient advocate, and my background is in psychology and in linguistics, and I hold a PhD in patient advocacy. So that's also my research field. I do both theory and practice. And what I'm going to talk about today is indeed a short summary of these different concepts, with some discussion and presentation towards the end about what we've seen in patient communities, but also in other areas, in order to facilitate access to medicines and diagnostics in circumstances when it's not going so well or not going as necessary. These are my disclosures, not a lot to disclose. There's one important point though, that this presentation, a previous version of this was originally developed for the Weekend Academy in 2019, and then reworked in 2021, and now I have reworked it again. So let's begin with the healthcare ecosystem and the very basic concept of why we call this an ecosystem instead of just a system or just an independent or an interdependent rather part of social and economic structures. We call this an ecosystem, which is a broader category because it's so complex. And I will come to explain what we mean by complexity in this case. Also because it includes a variety of stakeholders. The healthcare system across the world really affects basically all parts, all other structures of the economy and of society. It is an interconnected web of different relations, and we will look at that in some detail. And that also means that it includes very diverging and also converging interests, which actually, in many cases, will have to guide our work as patient advocates or expert patients, if you like. All around the world, this ecosystem is defined by some very specific challenges, very complex challenges, such as aging populations. Aging populations are an issue or pose an issue everywhere in the developed world, especially in what we call the Northern Hemisphere. So Europe and North America, also Japan. It's less of a problem, or a problem in a different way, in the Southern Hemisphere, where there are many more young people, but still there's a massive challenge around people aging. Also, we have to understand that social policy, health policy, and politics are deeply interconnected. So health policy is not just about health, it's also about the philosophy of the state, it's about the philosophy of society, it is about how society is structured and reflects these structures. So therefore, there's this deep interconnection, which we also must respect. We have to acknowledge increasingly the role of data and big data in this ecosystem, which just makes it even more complicated. And last but not least, as you will see as we proceed, that there's a constant need for a balance between the global economy and what the global economy dictates and requires and recommends, and also what the local needs are, because these are oftentimes contradicting. And I think that you could see a lot of examples for this, unfortunately, through the current war happening in Russia and Ukraine. This summary for the healthcare ecosystem actually comes from the European Commission. So they, in this policy document that I have linked here on this slide, that's where they explain how healthcare is structured in Europe, but it's applicable to all other systems around the world. And what I want to call your attention to is that while patients and citizens are in the center, and they rightly should be, so as patient advocates, that's obviously something that we are advocating for and should advocate for. But the whole ecosystem includes a vast number of different other stakeholders, such as companies, small and large companies, policymakers on different levels, so on national level, but also on local levels, education and research, which obviously includes universities, and maybe other schools, but also independent laboratories and research institutes, a variety of funders. Funders can be insurers, they can also be investors who work in the health sector. Then there's the third sector, or sometimes also called the civil society. So citizen initiatives like charities or associations, and patient organizations would fall into the category of associations, even though in some places like the UK, they prefer to call themselves charities. And obviously there's the health and social care sector, which is also included in this ecosystem, including health care providers, but also professionals. So people working in healthcare, or healthcare professionals, HCPs, as we sometimes abbreviate them. So it's a very big system, and if you want to make an impact as patients and patient advocates, or even activists in this wildly complicated system, we have to be aware of the sheer complexity and the different needs and interests that are that surface in this system, and we also have to understand how to navigate these. So, who are these different stakeholder groups? I've already mentioned this: patients and citizens. That's you. That's us, right? So we are both patients and citizens at the same time. So not surprisingly, there's also quite some research nowadays about what, for example, pandemics like the COVID pandemic, but also others like the HIV pandemic, how they have impacted citizenship, what it means or in terms of citizenship, to be ill and to live in society as a patient. So it's just an added level of interesting research and complexity as well. But also companies, policymakers, education, research funders, the third sector, and obviously patients and citizens and the third sector are closely related to each other, and healthcare and social care. And first of all, what we always have to consider when we try to jump into this pool of work and relations and interests, we have to understand who is connected to each other and in which way. How do they work together? Where are their interests overlapping, or where are our interests overlapping with other stakeholders' interests, and how we can use those overlaps or even those adversities for our benefit. And in this case, our benefit for the patient community is obviously having quick, affordable and reliable access to medicines and diagnostics. That's actually what we as patients and citizens would like to see happening. Obviously, is supported by reliable healthcare and social care systems and structures. So if you think about this in a more complex way, and this is what we usually describe through a stakeholder map, we get to, again, a very complicated, a very complex structure. And why I'm pointing this out so many times is because I want to make you as patient advocates aware of the fact that it is impossible, and it will remain impossible for quite some time now, to change the whole thing at once. Instead, we need to concentrate on certain relations, on certain connections, and some particular objectives in order to achieve change in this system, because it's so big and so interrelated that that changing the whole system doesn't seem to be feasible at this point. So I will encourage you as we move forward to pace yourselves and to pick those levels and those relations in this complicated map where you actually can really make an impact with the resources that are available to you, or to us rather. I brought you the 3 examples for demonstrating how this complexity is reflected on the national level. And these systems, these healthcare systems, evolved in order to reflect these different, sometimes diverting, sometimes converting interests, and also to navigate them, and also to make sure that all of these interests and needs and asks are somehow channeled and can be controlled by the state centrally. So this is an example here for the German healthcare system or healthcare sector. The 2 graphs show the same thing in a different way. So one starts with the healthcare system, and then describes the various functions and how they are related to each other. And the same is then also translated to an institutional level by enumerating the different institutions and bodies and boards that operate under these state institutions in order to keep the healthcare system going. It's equally complicated if you look at other constituents, if you like. This is care system, which is somewhat simpler than the German one, and this is the Greek healthcare system's structure and how that is built up. You see that it's equally complicated, and so when you want to make an impact in this in these systems, then obviously you will have to pick and choose where you want to advocate for change, and how you can do that. And obviously all of these systems are full of people who work there, and that will also provide an opportunity, or provide you with an opportunity, because it's obviously you interact with people rather than systems or institutions, but it's also an added level of challenge, because sometimes decisions or change or any evolution of a system can also depend on individuals, and then you have to change your strategy to work with a person, or to convince them about what they can or should or need to do in order to bring more equity, more equitability, more justice, if you like, into the system in order to promote the patient's interests. And additionally, all of this is also part of a very complex global system, which defines, especially in the field of pharmaceuticals, and to some extent also in the field of medical devices, although that's a little different, but still for pharmaceuticals and diagnostics, definitely it has some very specific rules that must be followed by everyone. These rules were worked out partly by supranational institutions like the United Nations, but also between states and between groups of states, such as global trade agreements. And then there's another level of all of this, which refers to patents and patent protection. I will not talk about patents in detail today, but that's another global regime that all pharmaceutical companies and also all states need to follow. There are also smaller and larger global NGOs. So the third sector is also represented on a global level. And then there's another interesting feature of this system, especially for pharmaceuticals, which is the trade-related intellectual property rights system, or TRIPS, which are part of the global trade agreements and provide certain exceptions to the rules described in the global trade agreements, specifically for pharmaceuticals and medical help, if you like, because vaccines are also covered by this. And then, there's this debate whether vaccines are pharmaceuticals or not, but for this case, they are. You may have heard about TRIPS quite a lot recently in relation to the COVID vaccines, and I will come to speak about that as well as we move forward. So our question for today, and in general as well, is how can you have and manage interfaces with all these different stakeholder groups from the position of a patient advocate or a patient organization, a patient advocacy organization. And if you think about the complexity, if you think about all this challenging environment, it's obvious that you need to be coordinating very carefully in order not to step on toes, or not to step on too many toes, if you like. You need to set your priorities. As I said before, you cannot do everything at once because it's not going to work. It's too much for anyone to do it alone and at once. And also you need to have a strategy. You need to know exactly with a plan what you want to achieve, by what time, how you're going to measure that. So it's complex work. It's not enough just to speak up and say that pharmaceuticals should be cheaper, or they should be more accessible, or you should do this, or you should do that, because it's not going to affect change. Instead, you need to build a strategy and move along that strategy. One example I've brought here is community advisory boards, and I'm sure that many of you have already heard about community advisory boards, which in this case, community describes the patient community. So these are advisory boards that are run and organized by the patient community. It's the patient advocates themselves who set the agenda and invite the participants, the researchers, the academic institutions representatives, or the authorities, and obviously also the pharmaceutical industry. The community advisory boards allow the creation or the leveraging of a two-way dialogue around improving the patient's well-being, and obviously also access in this case. Also, community advisory boards, or CABs as we abbreviate them, can address some key challenges that the patients face in terms of access, but also in terms of development and research. So where is development and research going? It allows discussion around clinical development pipelines and other issues, but obviously they are also vehicles of building capacity and building knowledge across patient communities. But you can also think of other examples, other similar examples that may be out there for this type of interaction. And it really is not, so the bottom line is not that you should choose one or the over the other. but rather that you should very carefully choose, in line with this first point, you should very carefully choose which vehicle, which tool you can or you want to use in order to achieve your objectives. Now, all of this is also facilitated then in the background through some institutional structures, such as at the European Medicines Agency, the EMA, which has over the last 15 years developed a very thorough system of patient involvement in their own regulatory procedures. Everywhere where you see the little blue blobs here, there is patient involvement, patient/citizen involvement in the development of materials or in taking decisions. These are the abbreviations explained for the different bodies of the EMA, and you see that the blue blobs mean patient input, and this little leaflet means that there's an outgoing document for the public coming out of the given institution or the work of this given body. And you see that everywhere where advice is given, all the committees, all the working committees include patient representatives. The EMA has its own pool of patient representatives, which is partly publicly accessible or available, but they don't do like, you know, kind of matchmaking, or so it's not like you can ask them to make a patient available for your work or your project, but you can know, it's public knowledge who is part of these different organizations, who those patient experts are, and also it's well described on the EMA website what they do. So it's a quite transparent system, which itself was also developed together with patients, which, as I said, started about 15 years ago, and ever since it's been rolled out, introduced, and developed gradually. So that's already a good structure in the background for all of you to rely on, and to say that, look, even the EMA takes patient involvement in their own regulatory decisions seriously. So obviously, there's a place for patients in this system, despite its complexity, despite all the other challenges that I just enumerated previously. There is a legitimate place and there is a role for patients in this. Now, breaking the system down a little further, I think it's necessary to talk about reimbursement. Because, you know, regulatory approval and reimbursement are not the same things. Regulatory approval means that the pharmaceutical, that the drug becomes available on the market. So it's approved for prescription, it's approved for use, and anyone who chooses to do so can legally use the given pharmaceutical or treatment option. And the reimbursement decision is about whether the state or the payers, the insurers, and the insurers can be the state or it can be independent insurance funds or institutions, whether they pay the price for it in whole or in part, and that again differs from country to country, from system to system, whether the full price is reimbursed or whether just a part of the price is reimbursed, and then there's a copay from the patients who get it prescribed. So the European Medicines Agency, the EMA, grants the marketing authorization, which means that the medicine is safe to prescribe. But in order for the patients in most countries, in order for it to be available, to be accessible, they also need a funding approval from a national authority, right? So that the price will be paid by the health insurance fund or whoever is the payer in the given country. Now, the reimbursement decision refers to how healthcare systems decide on and how they pay for new medicines. And then how the price is set, that happens either before or at the same time as the reimbursement decision. So they are always separate, kept apart, these two decisions, but they can happen in parallel. So there's first the drug development happening. So you know that there's a phase 1, 2, 3 trials. Then comes the marketing authorization, and if it is granted by the EMA, then comes next the national reimbursement decision. So that happens on the country level rather than centrally. And again, there's a lot of discussion, especially in the European Union, about whether this process could also be centralized. We are not there yet, though. Now, these decisions by the healthcare systems are obviously very difficult and very, very challenging, especially because no one has unlimited budgets for healthcare. So these decisions include whether the health system should invest into a new technology at all, or are the old technologies that are already available sufficient, and maybe you don't need a new one. Will there be an opportunity cost to funding new medicines? This means that if I fund this new treatment option, I may need to take money away from funding other developments, right? So that's the opportunity cost for the new medicines. How can we decide what are the priorities? What is more important? Is the prevention of the spreading of COVID a priority, or is the prevention of breast cancer a priority? And these are difficult decisions that need to be discussed and supported by evidence in order to be able to decide. Also, how can we ensure equity in the healthcare system? What is valuable in the first place for the patients, and what is valuable to the public? And if we have a limited amount of resources, then what's the most efficient use of those resources? So you see, it's all very, very complicated matters that the state and the state's institutions need to take in this case. Now, there are therefore, or consequently, and not surprisingly, there are very different systems that have evolved around the world around reimbursement decision making. It's usually based on a cost-benefit analysis, which then also means that you have to have a good understanding of what is the cost and what are the benefits. And that cost-benefit analysis is then based on these fundamental questions. How valuable is the new treatment? What do the clinical trial data say? What is the cost of the medicine? Do we have enough money to pay for it? So can we afford it? And do the benefits of this new treatment option actually outweigh the costs? Now, this is then a very complex and again, a multi-layered decision. So there may, for example, be different bodies for different types of medicine, depending on their volume or depending on their price, and therefore the procedures can also be quite different that are applied. They may be they may be simpler, or they may be more complicated. And in order to facilitate all of this, this process, there's also health technology assessment, or HTA, which has been introduced in not all countries, but in an increasing number of countries, which informs the decision about whether or not a new medicine should be funded, should be reimbursed by the state. So health technology assessment does not take this decision. They just supply the evidence, which is not only about clinical effectiveness or clinical safety, but it's about also a number of other factors in order to facilitate this decision about reimbursement. Now, if you look at how different these approaches are. You can form certain clusters around the world, and I think that this particular slide is based on, or these data are based on WHO Europe, which is a much broader area than just the European Union. And then you can find certain clusters. So some countries look at therapeutic benefit of a medicine. So that's the primary objective that they will, or key criteria that they will look at. Some others will look at medical necessity and priorities. Some others will concentrate on safety first, yet others will concentrate on cost effectiveness, and also look at the budget impact, which obviously these different perspectives also mean that their methodologies will be slightly different in order to come to a reimbursement decision. On top of all of that, there may be different criteria for rare conditions, because rare conditions, because of their rarity, may require a completely different approach, where, for example, value and value versus cost, or cost versus price may look very different from medicines that are in broader use. So again, if you want to do advocacy in this field, then that's another point that you have to consider, that all this system may look different, even more different for rare conditions and ultra rare conditions. Now, also because all of these countries are structured in a different way, and their societies have evolved differently, and their historic background is also different. So how healthcare systems are financed are also quite different, which is also a point that you need to consider when it comes to reimbursement, because it defines also how much money is available and how that money can be or should be spent. What we find is quite common in some of the larger countries like France and Germany, is the social health insurance system, or socialized health insurance system. So it's a solidarity-based health insurance system where everybody pays into a big pot of money, and then that is spent on the care and treatment of others who fall ill. So you will find this in Austria, Belgium, France, and Germany. It's sometimes called the Bismarck system because General Bismarck invented this in Germany back in the years. And you find very similar structures, even with slight modifications, in Central European countries, and also in the former Soviet Union countries, because the original healthcare systems in those countries were structured again in a similar way, and so they were just slightly modified after the political changes in the 90s. So the financing healthcare is often funded through insurance contributions made by the employers and the employees, and also state subsidies. So everybody makes a contribution to this fund, to this pot of money, as I said. Also, oftentimes there are mandatory schemes for everyone who's employed to pay into the system. Sometimes but you can also find other systems which are financed through general taxation, which covers all residents, such as in the UK, the NHS is a classical example, but the same applies to Italy, Spain, Portugal, Denmark, and Sweden. And then the scope of services is identical for everyone who's covered, and then you can obviously buy and add services on the free market, and then these services, but the fundamental services are often offered by public institutions, so that hospitals or medical care facilities are owned by the local communities, or they are owned by the state. So that's what's meant here. And then obviously there's also an add-on system to this through voluntary health insurance schemes, which are again common in many countries. So you can take out an extra private insurance, which will add services and maybe priorities or privileges within the healthcare system. Now, also in pricing and reimbursement, as I said, there are certain differences. In some countries, this decision is taken concurrently at the same time. So the decision on how much the medicine will cost and whether it will be reimbursed is taken at the same time, or is decided at the same time, rather. In Italy and Portugal, it's the same institution that is in charge of the decision, but they take the decision separately, but it still happens in the same institution. And then there are certain price controls as well. So there are thresholds, there are limits that are set, how much money can be spent on a different or on a certain treatment option or a certain medicine. And so actually, if you look at the whole thing, and if you compare different countries, and ultimately you come to the decision, or you come to realize that basically anything goes. So different countries, different systems, and a very wide variety of possibilities. There are some rules to how reimbursement should happen. In EU member states, there's a requirement to comply with the Transparency Directive of the European Union. And the provisions of the Transparency Directive provide that decisions on pricing and reimbursement of medicines must be taken within 90 days after the dossier submission. The dossier is a summary of all the information and knowledge, clinical evidence about the given drug. Or it can be 180 days for joint pricing and reimbursement decision, right? So if these two decisions are taken at the same time, then the time can be extended. Very often, these timelines are not respected. Even though these competent authorities need to follow some very transparent processes in how they take these decisions. And they also have to contain a statement of reasons why they took the decision that they took. And also then the manufacturers have the possibility to appeal if there's, which then extends the deadline, obviously, if they disagree with the decision of the competent authority. And unfortunately, we can see that there's a lot of creativity in how to delay these decisions, because then the bargaining can continue in the background. So that's another thing that we as patient advocates have to be aware of and have to look at carefully. So there may be huge differences actually in the end in how certain countries fare. So for example, if you look at this particular comparison, which comes from the WHO, if you look at, sorry, this comes from the OECD, but it applies to WHO Europe countries. So it's really interesting to see how much countries spend on per capita on pharmaceuticals. And you see, so it's pharmaceuticals and other medical non-durable goods or consumables. And it's interesting to compare, for example, Denmark, which stands here, and this was in 2015, which stands here at 342 euros versus Germany, which is 766 euros. So it's really interesting to see why, or understand where this difference comes from, right? So why can Denmark achieve much lower prices, obviously, than Germany. And the reasons may be systemic. The reasons may also be not easy to understand. They may be related to transparency. They may be related to some systemic challenges. They may be related to how the country approaches healthcare in general. But for us patients, it's important to understand that there are these differences, and then to understand how these differences are structured and how we can use them as advocacy tools in our work. So reimbursement decisions are taken on the basis of an assessment of the value, clinical effectiveness or cost effectiveness to decide on reimbursement. And this is then increasingly supported now by or through health technology assessment. And health technology assessment will discuss much more than just the price and whether the price is right for the money. So what is health technology assessment then in the end? Its aim is to inform policy at national, regional, or hospital level. And it's a multidisciplinary process, which is, I think, very important to point out. So it's not only about the price, it's not just an economic consideration, but it's about the medical, the social, ethical, and economic issues that are in play in case of the introduction of a new drug or of a new health technology. So it may also be an operating procedure, or it may be a medical device or any other form of health technology that is used in healthcare. And they do that in a systematic, transparent, unbiased, and in a robust manner. So what's its role then in the reimbursement process or the reimbursement decision? In some countries, they have there are formal HTA bodies. Oftentimes they inform the reimbursement process, as I've mentioned already before, or maybe they redevelop, they draft the reimbursement decision itself. The decision is not taken by them then, but they formulate how it could look like and what the arguments are. There can be national and there can be local HTA bodies, and Spain is a good example for that. And the bottom line is that they produce guidance or decisions on the value of the new medicines to the healthcare system, right? And this value is not just about the price or the cost of the medicine, but it's a much broader approach. The history of health technology assessment is not very long. It's still a relatively new approach. However, we can see today that it's spreading everywhere in the world. Many countries are using or considering using the health technology assessment approaches of NICE, of the UK's HTA body, which is very good for us patients because it essentially relies on patient involvement at every stage and every level of forming their opinion and of preparing a decision. But there are health technology assessment bodies also in Latin America and in Asia, so it's not a European phenomenon exclusively. There are certain problems, obviously, that they have to face. These bodies and the work that they do. First of all, that if they take a reimbursement decision that impacts on national health budgets, so it's very difficult to centralize or to streamline this procedure, even though there have been many attempts to develop a European health technology assessment agency. There's this counter argument that yes, but the money has to come from the country budgets. And all of these countries use their own systems. There's very little harmonization consequently, and there's no centralized procedure as yet. It may duplicate sometimes the regulatory process, which is a waste of time and money. Sometimes it also is misused to delay access to the medicine. So the longer the procedure drags out, the later you have to start paying for a new treatment option. And even though patient engagement is written on the flags of health technology assessment agencies, they do not always live by this rule of engaging patients. And then some of these bodies are good examples for the opposite. So like NICE, they use patients and patient input very extensively, and the same is true for Sweden, for example. These are the different factors that are then considered by health technology assessment. Is there an unmet need for a treatment? Is this really necessary? Is it an innovative treatment, or is it just maybe the repetition of something we've already had on the market? Who will benefit from this primarily, and what is the current pathway of care, and does it change as a result of the introduction of a new technology? What are the costs versus the benefits of a new medicine, and what is the long-term effect of the drug, and not just clinically speaking, or medically speaking, but also what are the long-term societal effects of the introduction of a new drug. And then obviously also, is this a rare or is this a more common disease? So what is the number of patients affected, and which subgroups are affected by it? And it's streamlined a rather simple process itself. Obviously, a lot of work happens in the background. But from the submission of the dossier of all the evidence that has been amassed to the relevant HTA body, it goes through different levels, different degrees of evaluation, and then at the end there's a guidance issued about on the medicine, with maybe a recommendation of whether it should be part of the national healthcare system or maybe not. And that's also the place, the health technology assessment stage is also the place where, for example, patient-reported outcomes matter a lot, like quality of life, because if they want to assess the long-term impact, the long-term effects, benefits versus the costs of a treatment option, then quality of life becomes extremely important. And that's exactly what patients and patient advocates can bring in very well. Obviously, they will also deal with cost effectiveness. So that's also an economic evaluation that's also there. And one common methodology that's used by NICE, but also it's used by others, is the quality adjusted life years approach, or abbreviated as QALY. If you want to learn more about what QALYs are and how they are structured, and why they matter, then you're very welcome to look it up on the EUPATI website, the European Patients Academy on Therapeutic Innovation, which gives a very detailed explanation of how QALYs are calculated and why they matter. But actually, a QALY describes how much longer you live with a good quality of life based on the administration of a new treatment option, and how much it costs to extend your life in good quality by 1 year. What would be the cost of that based on the given new treatment option? So this is how an HTA body comes to a decision. And then you may ask, okay, but why are we talking about this so much? And the reason why I'm talking about this so much is because this is exactly the place where patients can make the biggest impact. Not just because they are systematically included in HTA decisions, increasingly more and more, regularly at NICE, but also to an increasing extent at other bodies as well. But also because this is exactly where patients can make their voices heard in a very, very meaningful way, right? So this unique experience of the patients, their preferences, their contributions are best made at the HTA level. so that the patient's view matters and their preferences must contribute to the HTA decisions. Living with an illness is something unique that cannot be described by anyone else than the person who actually lives with the illness or is affected by an illness. So it can also be a family member or a caregiver. In case of children, that's the common approach. And also there's a very unique knowledge amassed in patient organizations and patient experts, which is described as unique perspectives oftentimes. So these experiences that the patients have, which may be good or bad in healthcare systems in terms of the diagnosis or the support of the healthy living and also the treatment, what are their preferences, what are their needs, all of these can be then reflected by the patients. Oops, sorry, I pressed the wrong button. Can be reflected by the patients most effectively. Providing a human context, making sure that that important questions are answered, that need to be answered by the questions, resetting preconceptions about what the effect of a technology will be. So impressions about side effects may be very different on the side of patients from what others may think about certain side effects. And there's been a lot of research about that, also spearheaded and led by patient communities, but also addressing information gaps in information provided by the company, such as quality of life or the use in clinical practice, where patients can contribute additional information to the health technology assessment process. So that's the place for patients to make a real meaningful impact. And last but not least, that will also improve transparency, legitimacy, relevance, and also acceptance of a new treatment option if patients were also related or involved in making that decision. So you see the whole thing, and I was talking now more extensively about health technology assessment, because that's a specific place for us patients to be present and to make a formal impact. But there are many more other areas in this, what sometimes people call a twisted system, such as intellectual property regulations, where there's a lot of work, a lot of advocacy work happening in order to facilitate access. There are also the question of patents. How do we handle patents? Are they necessary? Are they beneficial? Or are they rather an object or a hindrance to access? How do we handle certain tricks by patent holders, such as evergreening? So when a drug is changed only very slightly, but there's no clinical improvement, there's no clinical impact or change, there's maybe a slight formulation change, and then the patent is extended by another 20 years, saying that it's a new, completely new treatment option. What about the trade-related intellectual property regulations, or the TRIPS, which is another area where we've seen a lot of work happening? How do we handle parallel imports, which seem to be, because of how the market is structured, seem to be quite present still, especially across Europe? What about mandatory licensing and voluntary licensing, which are part of the TRIPS possibilities? And how do we handle clinical trials as access vehicles? So when a clinical trial is organized in a country or in a location in order to allow people who don't have any other options to have access to innovative treatment options or innovative medicines within the framework of a clinical trial. Unfortunately, this still happens. And there are other alternative models for different or better access and for different or better approaches, well, maybe not better, but different approaches to research and development. such as generics, the use of generics. And we in many patient communities, especially where I come from in HIV, have been advocating for generics, for the use of generics for many years. But also there are direct negotiations on country level, which has its ups and downs. There may be some parallel or semi-legal routes of access that are being continuously explored and used by several patient communities. Obviously, there's the joint procurement procedure of the European Union. There's a medicines patent pool, which is a patent pool of medicines, especially for infectious diseases, that operates with donations from patent donations from companies. And then there are also proposals for how you can de-link services, how you can de-link research and development from your revenues, so that that this age-old basis for reference that you must finance research and development from the income of successful drugs in order to be able to develop new successful drugs. That's why the prices of drugs have to be kept high so that you can fund the rest. Some researchers, some people, some economists challenge this approach, and they say this may not be the right way to go, but why not keep these two activities separate from each other and not create a direct link between the two? Something similar is promoted by the Affordable Medicines Initiative and the Drugs for Neglected Diseases Initiative, or DNDi, so Drugs for Neglected Diseases Initiative model, which tries to look at existing drugs which were perhaps not so successful through the development process, and they try to figure out how they could be used differently for other diseases, for other illnesses. And they do this in a very interesting structure. So generics is something that we strongly recommend to all patient constituencies to consider if they are feasible. If there is a possibility for generics to appear in your disease area, which may not necessarily be the case in ALL or other acute leukemias, however, it may still come. We know there is strong evidence that generics usually bring down the prices very significantly, and as it happened with HIV, generic competition reduced the prices by 99%. So that's a very considerable margin of reduction. Or the joint procurement procedure that you may have heard about recently around the COVID-19 vaccines, which was actually originally devised for vaccines within the European Union. The whole process started already in 2008, and then it entered into force. It was adopted by all European Union member states in 2014. It is a slow process, with some progress in some of the countries, such as the Benelux countries and Austria. It is by itself a very reasonable, a very good approach. It says that for the purpose of vaccines or any other health technology, the European Union gets together as a single market, and they bargain as the European Union in the frames of the joint procurement procedure. They bargain with the providers, they bargain with the pharmaceutical companies or with the vaccine manufacturers. Instead of each country separately, they would do it together. They tried this for the COVID-19 vaccines. It didn't go very well, but that does not mean that the system itself would not be meaningful. Because of the lack of time, because of all this pressure that was happening around the COVID-19 crisis, this process had its downsides, but the process itself is a very meaningful and especially very good, very promising process for the patients, because obviously if you bargain for 500 million people, then it's much easier to bring the prices down as opposed to bargaining on behalf of every single country for your 10 or 8 or 80 or 18 million people, and then having different agreements for the 27 member states each. And also then there's the other important initiative, which is the Affordable Medicines Initiative, or it's called the European Alliance for Responsible Research and Development, and affordable medicines. And these are their objectives: securing affordable prices now, putting an end to pharmaceutical monopolies, and also full transparency of pharmaceutical research and development, and promoting a new biomedical research and development model, which is based on delinking pricing from research and development. I'm bringing you these examples to show how much work has already been done in patient communities around all of these issues, and that you are very welcome to join this work. So you don't have to reinvent the wheel, you don't have to start this all over again, but there's a lot of work that you can join and that you can advocate for, such as working together with civil society organizations on promoting the joint procurement procedure, or joining the Affordable Medicines Initiative, or any other such initiative, because the complexity and the challenges of the system will not allow you to achieve results on your own. And so we have to do this together across disease areas, across borders. We need to work together in order to come to a meaningful result. And at the end, I think that another thing that we really need to see very clearly is that we also need to do some theoretical work amongst us in patient communities, and then together with the other stakeholders. And the first thing should be a clear definition of what value means. Value is not equal to price and to cost. So, because often we use this interchangeably, we speak about value, but we mean cost. We speak about cost, but we mean price, and vice versa. So it's quite confusing. So first of all, we need to make sure that we understand that value, cost, and price are not the same things. And we also have to understand what is value for us, what is value for the patients. And once we can define it, then we can also defend this definition and this concept in an effective way, and we can make it work. So I think that that's where we need to start in our patient communities, and then everything else comes afterwards. I have another example on my slides, but I will not go into that. Once you get the slides, or once it's uploaded by Samantha on the website, then you're very welcome to look at those slides yourselves. And obviously, I'm very happy to receive questions from you by email or through social media if you have anything that you.
Thanks, Tamas. I think you're frozen now.
Very much for your attention.
Yeah, thanks a lot. Yeah, it was a lot of information. So as you mentioned, I will upload the recording of the webinar on the website and also the slides, so people can refer to what you say. And if there are any questions, you can send that to me or directly to Tamas. I think everyone has your email address, so that shouldn't be an issue.
I guess so, yes.
But otherwise, happy to forward the questions to Tamas. And yeah, so if there are no questions, thanks a lot, Tamas, for being with us today.
Thank you.
And thanks for attendees to be also with us today. And yeah, see you for the next webinar, which is going to be on the 27th of April, and it's going to be treating acute leukemia in low and middle income countries. So another interesting topic, so feel free to join as well. And with that, wishing you all a very good afternoon.
Have a good one. Thank you. Bye.
Thanks, Tamas, again. Bye.